Hello, everybody. Welcome to BFR Tuesday. My name is Ed Cara. I'm the Director of Education for Smart Tools, aka Smart Cuffs. And I do this webinar every Tuesday, just do a little lunch and learn, meet and greet, answer any questions regarding BFR that I can answer. And then I usually talk about either a new research article that comes out or anything that's been super interesting to me. In the last week or so, I haven't seen too much. 4th of July and everything else going on, busy in the clinic. Haven't done too much outside research, but I do have some stuff to share today regarding pain control, and I'll kind of talk a little bit about that. But I want to always start off with, if you have any questions that you'd like me to answer right now, just type it into the chat, and you should be able to notice where the chat is in the upper right corner. Hit chat. And you can just ask questions, and I'd be happy to answer if I can. So I'll give a minute or so for people to get on and get on in while I organize my couple of slides I'm going to go through. All right, Doppler suggestion, we're good. Okay, good. I'm assuming that's good. Great, I'm glad it helps. Yeah, I can't wait to get these new cuffs next. Well, it's going to be in the next week or so, where we don't have to do this Doppler stuff anymore. It's going to be so nice. Any other questions for me before I kind of get started with what I wanted to chat about today? All right. So I'm going to share my screen. Okay, so what we're going to look at right now is BFR and pain control. I would say I have had the best results with pain control using BFR than anything else, mostly because of the time that that I have somebody. You know, I mean, it'd be great if I worked with people for 12 and 16 and 20 weeks at a time, but it really doesn't occur. Usually people come in pain. They're already part of some sort of physical activity, whether it's CrossFit or tennis or golf, regular fitness, yoga, and they're looking for me to control their pain. So especially with tendons, they're so hard to treat, especially things that have been going on for a long period of time. What I have found is when I combine my manual therapy with BFR, the pain levels drop, people get more active, which I think is good for the tendon, and their recoveries are so much faster. So that's not just tendons, it's a lot of different areas, but tendons are my hardest thing that I treat. They're just tough, especially in older individuals. And you're trying to keep people active and moving. The Achilles tendinopathies, the lateral epicondylitis, the medial epicondylitis, the supraspinatus tendinopathies, these are just all really hard for us manual therapists to treat. We know they require exercise, but if we push them too much, then they're just going to keep aggravating the tendon. So that's where BFR comes in, because we can use really light loads. We can load the tissue. A recent study last year demonstrated tendon loading looked to be pretty equal to high intensity loading as far as cross-sectional area and tissue regeneration, which was a surprise because other studies have looked at it and didn't think that that was the case. Before, we used to treat tendons, you know, really without BFR. I mean, usually we would do kind of ischemic preconditioning and then heavy loading, but we had to be really careful with those. But now, after that last study, which still needs to be validated, by the way. Meaning that needs to be kind of shown again because it was so different than what other people have found. Now I just kind of get after it. Now I just manual therapy. Sometimes I use shockwave for those stubborn cases, and then right into some sort of loading with BFR. Now, what I want to talk about today is that with BFR, you're going to get this decrease in pain control. I mean, I can't tell you how many people have come in with irritation to the knee, the meniscus, something. We do some BFR exercises. They get done and they have no pain for hours upon hours. And it allows for more activity, more movement, which I think is always good for a joint. Not always, but for the most part. So there's been a few studies looking at the analgesic response. And what I think the big take home from this this slide from Faraz in 2017 is that they did both BFR, they did light intensity, and they did high intensity. And what you'll notice is that pre-post, reduction in pain. Pre-post, reduction in pain. Pre-post, reduction in pain. So no matter what type of exercise the people did, they had a reduction in pain. So we're so hesitant a lot of times because people are in a lot of pain to not get them moving. But what Mackenzie taught me with the spine is that if we get them moving in the right direction and not too much volume is defined as load, reps, and sets, and we give them enough rest in between, the activity is really, really helpful. You also look at stiffness in this study, pre-post, pre-post, pre-post. BFR, light intensity, high intensity, all help. The key to BFR, though, is that we can use light loads, mimic high intensity training, and still get very similar responses without loading the tissue too much. So of course, we all use these scales, 0 to 10 or 0 to 100. This is what I share with my patients, and let's just say, okay, well, here's how I define it. You let me know what pain levels you're at, so that way I know. And then this is how I prescribe exercise. So if I'm going to treat based on pain levels with BFR, let's say the person's at a 10 out of 10 pain. Well, they're not coming in my clinic. I get people that are in pretty good pain, but it's not like my emergency room days where people would come in with true 10 out of 10 pain. Most of my people are somewhere between 5 and 7, 5 and 8, about at the highest end. If they're above that, then my recommendation is get some pain meds, protect the tissue, but get comfortable. Like 10 out of 10, I don't treat. Those are emergency room. Those are high levels, and I don't want to live in high level of pain. So I would help say that you want to try to get something to help reduce that. So the way to read this is 10 out of 10 all the way down to 8 out of 10. We're going to use pain meds, protect. And I know some people are philosophically against pain meds. Fine. I like to give patients options. I mean, I don't want to push my philosophy on them. I can give them guidance. And this could be over-the-counter pain meds. This could be prescription pain meds. But usually if you're a 10 out of 10, I'm sending you to pain specialists that I use. And you're getting something, especially for the spine. Now, once we get to 8 out of 10, I call this little area between active and passive threshold, meaning at 8 out of 10, I can start passive modalities to help your pain. Interferential, electric stim, dry needling, active release, like any of those things to try to get pain levels down, somewhere between 8 and 5. Once I can get somebody down to a 5 out of 10, then I'm going to start more active therapy. Between here and here is going to be more passive type therapy. With passive therapy, we can use passive modalities like stim and stuff, range of motion exercises, reciprocal inhibition, not necessarily with BFR. If I can do, if there's not a lot of swelling, I can do something called cellular swelling protocol. And I haven't really seen this change pain levels too much unless I add e-stim to it where they're getting a little bit of contraction. But again, I don't want to make people uncomfortable. So these are the type of things that I will do between this 5 and 8 out of 10. As pain levels are dropping and we get to this 5 out of 10, I'm going to start adding more active exercise, isometrics with or without BFR. I'm still including passive modalities, which might be like active release technique, dry needling, manipulation. So I usually will combine these within a treatment session, and then their home exercises are what I've done in the clinic. Everybody gets home exercises from me. Now we're going to go passive and active, but instead I'm going to use isotonics. Isotonics meaning eccentric and concentric, whereas here we're just using isometrics because usually the pain levels are too high to do anything more than that. So passive and active therapies probably isotonics, either eccentrics or concentrics or a combination of both. Pain levels are still dropping. Now I get you to a 1.5 or 2 out of 10. Now I'm going to be using my passive therapies for range of motion primarily, and I'm going to be doing some sort of concentric or eccentric. I like eccentrics a lot, so I definitely use eccentrics a lot. Eccentric loading, meaning I'm only lengthening the tissue. I'm not doing a shortening. So what it might look like is I do a bicep curl for a bicep tendonitis, and they're only doing the lowering. I grab my hand, I bring it back up, only doing the lowering. So I'm stressing the tissue, I'm causing mechanical stress, but I'm not overloading the tissue. And so using kind of this pain guide, I was trying to put on paper, like, how do I know what type of exercise to prescribe somebody, whether they're at a 1 out of 10, 2 out of 10, 5 out of 10, 10 out of 10. And this is kind of what I came up with. So any, stop sharing there. Any questions or change sharing? They changed this up on me. Oh, stop sharing screen. Okay. So any questions around using the different types of exercise? So what I would take home from that is that we can use passive BFR. We can use passive BFR would be your ischemic preconditioning, meaning there's no exercise involved. Could be your cellular swelling with E-stem. We can also use isometric exercises. Isometric exercises mean there's no movement of the joint, so you're just getting contraction, relaxation. Then you can start to use eccentrics or concentrics, depending on what your philosophy is and what you like. But really the whole take home from this little 12-minute chat is exercise pretty much trumps everything as far as getting rid of pain and getting people moving. And so we want to move towards that as quickly as possible. Would I share that graph? Sure. Let me see what I can do. I can probably take a screenshot and I'll just share right in here. And I would give you anything I got. Let's see what we got here. Trying. All right, it's not letting me. Let's see, add a resource. Oh, you know what I can do? This is what I can do. I got a link. So that link will get you that screenshot that I just took for you. All right, any other questions for me today? It's 1:15, witching hour for me. That means I got 15 minutes to eat before my next patient comes in. Anything else? If you have anything, let me know. Shoot me an email, ed@edlacara.com. What else do we have coming up? Smart Cuff Academy, the online training portal for Smart Cuffs will be coming out probably next week. We're almost done. Every single person that's purchased or anybody that purchases in the future will have access to some free programming to get used to BFR and get on board with that. Any certified coaches can become part of my training team. And then the people that want to, I can refer other people that come into the system and then you can be matched up with somebody to help them through their BFR journey. So lots of opportunities for both users, coaches, therapists, trainers, all those things. All right. Thanks, you guys. Have a great week. Next week, I am taking off. I will be in Florida, so I won't be doing a webinar. Take a little vacation, but I will be back in 2 weeks. All right. Thanks a lot. Bye for now.